manage pudendal neuralgia. But most of us, we do not use this pudendal nerve block to manage acute postoperative pain. I hope after this talk, lot of lot of you will be using this block as a new block in your armamentarium. Now coming to the history. This block was first introduced by the Muller in 1908, who gave this block in ischiorectal fossa with the idea to block pudendal nerves. Kovacs in 2002, he discovered ultrasound-guided techniques. He used this technique in volunteers. On the base upon this Kovacs technique, Zoffel, along with his colleagues Peng and Vincent Chang, he published an article, Feasibility of Real-Time Ultrasound for Pudendal Nerve Block in Patients with Chronic Perineal Pain in 2008. So this was his original image. He gave this block at the level of ischial spine. Why we should learn about this pudendal nerve block? Why this block is very important for us? Piles is a very common problem. Almost 1/5 of adult population is suffering from piles. And do you think it is a very small surgery and not associated with pain? According to Derrins, 65% of the patient they suffer from moderate to severe pain after the hemorrhoid surgery, at least for 3 days. Let us see what the prospect guidelines about hemorrhoid surgery, this guideline suggests. According to this guideline, bilateral pudendal nerve block is a preferred lesion anesthesia technique to manage acute postoperative pain. But what are those procedures which we should not use? One of them, which we very commonly use, is the spinal anesthesia. So it is a not recommended list because spinal anesthesia is associated with venous engorgement. So these piles may further bulge and may make the surgery more difficult. Another is intrathecal opioid, means morphine. We cannot use intrathecal morphine in these patients because intrathecal morphine is associated with constipation. So this constipation will make motion more painful. Perianal infiltration with local anesthesia agent and the liposomal bupivacaine, which was the common practice in previous time. So it was found ineffective. So this technique also should not be used. Now the Sahin, he compared pudendal nerve block with the spinal anesthesia for proctological surgery. And what he found that pudendal nerve block offers advantage of less pain, rapid recovery, and less urinary retention and better surgical field. Mori compare pudendal nerve block with the penile block and in 2023. And according to his study, though quality of analgesia and duration of analgesia was similar in penile group and pudendal nerve block group, but the surgeon satisfaction was more in pudendal nerve block group. Sometimes penile block is associated with the hematoma formation, which may lead to difficult surgery. And there one more controversy which rife around the association of the caudal analgesia with urethral-cutaneous fistula after the hypospadias surgery. Lot of studies which say that higher risk of urethral-cutaneous fistula formation and other urethroplasty-related complication with the caudal block. But most of the other study, they do not support this claim. This claim is not substantiated, and there was no association between cause and effect relationship was found between caudal block and erythrocutaneous fistula. So overall conclusion is that caudal block is not associated with high risk of erythrocutaneous fistula. But certainly duration of analgesia is lesser with the caudal block compared to pudendal nerve block. Lot many studies are done for the hypospadias where pudendal nerve block was compared with the caudal block. But Nakamura, this study is very recent study which is published in 2025. It is a meta-analysis systemic review where author has compared all the technique like caudal block, perineal block, pudendal block, and the penile block. And according to this study, the pudendal block would provide better analgesia than other regional anesthesia methods in terms of pain scale and analgesia duration. Other than the hemorrhoid surgery, other indication of the pudendal block are the perineal surgery, circumcision, penile prosthesis, episiotomy, second stage of labor, transrectal prostate biopsy, transurethral prostatectomy, catheter-related discomfort. Complications associated with pudendal nerve block are the pudendal nerve injury, vascular injury, intravascular injections, sciatic nerve palsy, because sciatic nerve is very close to the pudendal nerve. Muscle needle path is very long, so it may cause pain, muscle pain. Most common complication of the pudendal nerve block is the urinary and fecal incontinence. Patient may complain of numbness in pudendal nerve area. Before going for pudendal nerve anatomy, we must understand these bony landmarks. This ivory color structure is the ilium, red one is the pubis, and purple one is the ischium. This is the orbital obturator foramina, ischial tuberosity. This is ischial tuberosity, ischial spine, ala of the ilium. Now, let us see how the ultrasound image is found when we scan from posterior superior iliac spine up to the ala. So it is a slanted line. It casts a slanted line. But when we go further down, parasacral parallel shift. So similar method where we can basically which technique we use for the sacral plexus block. So at this level we will get parrot beak appearance. When we go further down at the level of ischial spine, again we will get a horizontal line, which is caused by the ischial spine. When we go further down, when we move further caudally, at the level of ischial tuberosity, it will appear as inverted U shape. Two ligaments are very important: sacrospinous ligament and sacrotuberous ligament. Sacrospinous ligament, which joins ischial spine to the sacrum, and sacrotuberous ligament, which joins sacrum with the ischial tuberosity. So sacrospinous ligament is anterior, sacrotuberous ligament is posterior. So when we scan, this image will appear at the level of ischial spine. Ischial spine and sacrotuberous ligament both cast hyperechoic image, but bone will cast an anechoic image, while this ligament, the sound wave may pass through this ligament. So again, this two muscles which are very important. One is the obturator internus. So obturator internus, it originates from the inner margin of the orbital foramen. It wing around the lesser sciatic notch, and it inserted at the level of greater trochanter along with the superior and inferior gemini. So under ultrasound, this is the image formed by the ischial tuberosity, and this muscle is obturator internus. Another important muscle is the superficial transverse penial muscles, which is originated from ischial tuberosity. This is iliophilia, iliopubic rami. So it is originated from the ischial tuberosity and it inserted at the perineal body. So under ultrasound image, this will look like a tape or ribbon. Pudendal nerve is formed by ventral rami of the S2, 3, and 4. Sometimes there is a prefix or postfix nerves as well. There are 3 branches of the pudendal nerve, which are inferior rectal, perineal, and dorsal nerve of penis. After its formation, the pudendal nerve, it comes out of the pelvis just at the level of ischial spine. It has a very short course. This nerve is medial to the sciatic nerve and posterior cutaneous nerve of thigh between the sacrospinous ligament and sacrotuberous ligament. So you can see here, this is the extrapelvic course. Extrapelvic course is very short, around 2 to 3 centimeter at the level of ischial spine. This nerve lies either on either side, either 1 centimeter medial or 1 centimeter lateral to the tip of the ischial spine. This nerve is the obturator nerve. Then again, it enters into the pelvis through Alcock canal or the pudendal canal, and then it gives its division. You can see this. This is the Alcock canal, which is formed by the duplication of the investing fascia of the obturator internus. This is around 4 centimeter at the 3 centimeter from distal to the from proximal to the distal. It gives off inferior rectal branch. So again, after passing through this pudendal canal, it gives off another branch, which is the perineal branch, and it continues as the dorsal nerve of penis or the clitoris. So you can see here how it is supplying the perirectal area, perianal area, and it is continuing as the at the level of the superficial transverse perineal muscles. It divides into the perineal branch, and it continues as the dorsal nerve of the penis. Same in the female. So this area, perianal area, and the vulvar perivaginal area, this is supplied by the pudendal nerve. While the area which is this green area, it is supplied by the inferior cluneal nerve, which is basically posterior cutaneous nerve of thigh. The anterior most part is supplied by the genitofemoral nerve. Similarly, in male, this penis is supplied by the dorsal nerve of penis. The ventral part is not supplied by the dorsal nerve of penis, it is supplied by the perineal nerve. And this is the transition zone. So dorsal nerve of penis is not sufficient to block whole of the penis. So we usually give this dorsal nerve of penis block just lateral to the dorsal penile artery by piercing this Buck's fascia. But even in male, whole of the pelvis is not supplied by the pudendal nerves. You can see here, this part is only supplied by the perineal nerves. Rest of the part is supplied by the posterior cutaneous nerve of thigh, and anterior part is supplied by the ilioinguinal and genital branch of the genitofemoral nerves. Sensory function of the pudendal nerve, sensation, basically it senses the external genitalia. It has 3 branches. Inferior rectal sense the perianal skin and lower third of the anal canal, while the perineal nerve is sense skin of the perineum, labia minora, majora, and posterior scrotum. Dorsal nerve of penis is supplies the skin of the penis, clitoris, except the ventral area. Motor functions of the pudendal nerve block. Pudendal nerve, it supplies the external anal sphincter, urethral sphincter, bulbospongiosum, ischiocavernosum, and part of the levator ani. Rest of the levator ani is supplied by the sacral plexus directly. There are various approaches described in the books, like transvaginal approach, transperineal. Transvaginal approach is basically used by the obstetrician. Transperineal approach, perirectal approach, fluoroscopic and CT guided approach by the pain physicians, penis guided approach, ultrasound guided approach. We are more concerned about all these ultrasound guided approach, posterior approach, at the level of Alcock canal and anterior approach. For give this block, we need a prone or lateral position while we give the posterior approaches block. A lithotomy position is required while we give this block at the level of Alcock canal or transpenial or anterior perineal approach. Frog-leg position is required for pediatric patient. For adult patient in adult patients, for posterior approaches and at the level of Alcock canal block, curvilinear probe is required. But for transperineal or anterior approaches or in the pediatric patients, linear probe is sufficient. We take a longer needle for the posterior approaches, while 5 centimeter needle is sufficient in pediatric patients. We usually take 0.375 to 0.5% dopamine 7 ml for adults and 0.3 ml per kg for pediatric age population. So this is the position which is required for pediatric patient. This question is under the hip. Patient is in frog-leg position. For Alcock canal block, this position is required, while for the most posterior, like ischial spine block technique, lateral or prone position is preferred. So this is the very recent video which this blog I gave today only. So for penis guided block, ischial tuberosity is felt, and from lateral margin of the anal verge, needle is directed towards ischial tuberosity. When needle is met with the ischial tuberosity, it is redirected slightly medially. You can see pulsation of the anal sphincter here. After adjusting needle and lowering the current, 7 to 10 ml of the local anesthesia was given in this patient. You can appreciate contraction of the anus. Now coming to anterior approach of ultrasound guided pudendal block, the advantage of anterior approach of ultrasound, this anterior approach, basically incontinence will not be a problem with this approach. This approach was described by the Paras in 2016 with the idea that this block can be given just under the superficial transverse perineal muscle. This nerve either lies in between the two plane, between the plane of the superficial perineal and the deep transverse perineal muscle, or in the substance of the deep perineal transverse muscle. So in his initial paper, he described this probe should be kept at the level of IP ramus. Then it should be moved laterally to locate the superficial transverse muscle. This is the area where probe should be placed. So how this probe should be placed between the perineal body and ischial tuberosity, and direction of needle is from either lateral to medial or medial to lateral. So now this is the video. Probe is placed between the perineum and ischial tuberosity, and this is the superficial transverse perineal muscle, below which you can see there is some vessel, which is the pudendal vessels. This is the IP ramus and ischio-cavernous muscle, bulbospongiosus muscle, and this is the deep transverse perineal muscle. This nerve is lying medial to the artery. Most of the time, this nerve is medial to the artery, which we can block from either. This is the artery. After putting this color, putting Doppler and color, you can see this is the artery. And we can give this block either from lateral to medial or from medial to lateral. In this video, this needle is coming from lateral to medial. You can see needle is coming from lateral. This is the artery. Just medial to the artery. Needle is adjusted. And after proper aspiration, 7 ml of the local anesthetic is delivered. You can see drug is spread as Bernstein, along with the Paras 4, described anterior pudendal approach with Vincent Chan. He described this technique of ultrasound-guided pudendal block at the entrance of the pudendal canal. The same technique was also described by Raja Reddy in 2022. So he did a cadaveric study as well as ultrasound-guided technique. So this is the video of posterior approach. So probe is placed at the level of posterior superior collective spine and it's slided down. This is the ala of the ilium along with the gluteus maximum and medius minimus muscles.
Mama,
So,
then
so
the
parasacral parallel shift method, probe is slided down in cephalic direction. You can see there is a breach in the lining, and this is the posterior border of ilium where we give parasacral sciatic approach. Sciatic block. This is the piriformis muscle. When we go further down, this parallel appearance will turn into the straight horizontal line. You can see pulsation here, which is the inferior gluteal artery, and this pulsation is of pudendal artery. This is ischial spine, and this is superior and inferior, sacrotuberous and sacrospinous ligament. This inferior, very close to this inferior gluteal artery lies the sciatic nerve. Most of the time, in 70% of the patients, this nerve is medial to the artery. This pudendal nerve is, and which we can catch by from lateral to medial direction. When you pierce this sacrotuberous ligament, you will feel a definite click. Then you further slide your probe at the level of ischial tuberosity, you will see inverted U-shaped ischial tuberosity. And this is the obturator internus muscle, and this is the pudendal vessel, pudendal artery, and Alcock canal. So this is ischiorectal fossa, gluteus maximus muscle, and we can give this block from lateral to medial at this level. So this is the transverse section of the hip, ischial tuberosity, obturator internus muscle, gluteus maximus muscle, and this is the area where we give this block at the level of Alcock canal. So this is the Alcock canal, which is formed by the investing fascia of the obturator internus muscle. So this is the levator ani muscle, and this is the obturator internus muscle. So now coming to my video. Patient is placed in, here probe is placed between the ischial tuberosity and anal valve. Patient is in the lithotomy position. You can see this is the ischial tuberosity. And direction of probe is cordocephalic and slight tilt towards outside. You can see this is the obturator internus muscle, ischial fossa, gluteus maxima, and levator ani muscle. So direction of needle will be from lateral to medial. This is the pudendal canal. Here we give our injections. So this needle is coming from lateral to medial, and after proper aspiration, will deliver 7 to 10 ml of local anesthetic. You can see proper drug is spread here. This is Alcock canal, basically. So for understanding the pudendal block, you must read this article, which is written by the Gomez. I have already shared this article to all of you. Now the pudendal block in pediatric age population, This technique was mentioned by Isabella in 2018. He mentioned transpenial approach. While in T Gray book, there is another method which is mentioned. You should slide this probe from ischial to velocity to the ischial spine, and you should give block at the level of ischial spine. But in very small kids, giving block at the level of ischial spine is very difficult because ossification of ischial spine starts only after 1 year of age, not before that. So identifying ischial spine is very difficult in pediatric age population. So this approach is preferred. In pediatric age population, patients are in from leg position, and probe should be managed in this position. It should be hold like this. Thumb should be at the lateral border of the ultrasound probe, and head arm should be rested upon the bed to stabilize your probe. This is the video. So probe is placed like this, and at the level of anal verge and the ischial tuberosity. After slide adjustment, needle is from out of plane because there is no place to negotiate needle either from lateral or from medial direction. You can see this is the ischial tuberosity. Get identifying artery is very difficult because artery is very small. So idea is to inject drug just middle to the ischial tuberosity. You can see this is the ischial tuberosity, and just middle to the ischial tuberosity, needle is coming and drug is delivered. But even after all the technique, there is a catch. This paper is published by the Pedro in 2015, which is published in American Journal of Obstetrician and Gynecologist. According to his study, this inferior rectal nerve, it was entered in the pudendal canal only in 42.3% of the hemiplegic. It means in 57% of the hemiplegic, pudendal nerve entered in rectal fossa without entering to the pudendal canal. So basically, according to his idea, if you give shell this block at this shell spine, 100% of the time you will be able to block inferior rectal nerve, which is required for the hemorrhoid surgery. So key point are the pudendal nerve block offers good post-operative analgesia for post-hemorrhoid surgery and for penile surgery. Blocking at ischial spine, it covers all the three branches, but it is associated with high risk of sciatic nerve involvement. At beginning of Alcor canal, block is better in terms of blocking inferior rectal nerve with lesser risk of sciatic nerve block. Anterior perineal approach can be blocked, which blocks perineal branches and dorsal nerve of penis, and it is a good option for penile surgery. For extensive perineal surgery, you need to address posterior cutaneous nerve of thigh, which can be blocked at the level of ischial spine with relatively higher volume of the local anesthetic. Thank you.
Thank you, Shishir. It was a wonderful presentation. Pudendal nerve block is a little complex block to understand for fellows. So you made it really simple for all of them, and you proved that understanding anatomy and then followed by that sonoanatomy is important before giving any block or for understanding any block. Thank you. It was wonderful presentation. I will
Thank you, Dr. Atal.
open the forum for the questions. Ankit has joined, Devesh has joined. Any comment from Ankit, Devesh, Neeta ma'am
Thank you,
has
Dr. Shishir.
Hi, Devish.
Wonderful presentation, and we use it regularly, but I'm using out of plane approach, and much easier over the periods I have developed this block is you look at the anal verge, anal opening, and the ischial tuberosity. Midway, if you keep your probe, you have kept your
Yeah.
probe slightly obliquely. I generally keep midway between those 2 points, and I use a outer plane approach because coming in plane either from lateral to medial or medial to lateral, at times aligning all the structures is little difficult. And the point which I've grasped over the number of years is that as you pierce the fascia of the superficial transverse peroneal, we are looking from the pelvis side. As we pierce, we get a definitive pop. So at times, as you rightly said, we are not able to visualize the pulsations of the internal pudendal artery. If we are able to visualize, then our like the next step becomes very easy because the neurovascular plane is in the similar plane. But if you're not able to visualize, a gentle visual and a tactile pop we get. And as you said, we can stay closer to ischial tuberosity versus anal verge. I prefer to stay midway between that. If we go too lateral, then there are some glands there, which I discussed with surgeon. Maybe uh, if we enter them, we are likely to induce a little infection, but we have cleaned it well. That is more of a theoretical risk. I do not know whether it translates into a practical risk or not. So when you see the pulsations, the game becomes very easy, either medial or lateral. And it diffuses like this, entire as you have shown. But if the pulsations are not visible, then rely on that pop. It's a very definitive pop that we get.
Actually, you're talking about transperineal approach, anterior approach, Dr. Divesh.
Yeah, I'm talking about anterior approach. Anterior approach.
Okay. So I basically try to put my probe in that way that this muscle, it appears like as a tape. Okay.
Okay.
I align usually this probe by rotating medial or lateral so that this looks like a tape, and this artery, it lies very close to the IP ramus.
Mhm.
If you focus there, most of the time you will be able to find this vessel. But for the Alcock canal approach, the idea, the trick is here, just rotate your probe from, just face your probe from medial to lateral direction.
Okay.
So
You mean the
in that
lateral
way,
should
you will
be up?
medial to lateral, like outward. In
Okay.
that way, you will be able to negotiate your needle, and visualization will be much easier and better.
So I have to
Otherwise,
ask you, what is your
yeah,
rationale of choosing Alcox over anterior approach? When the anterior approach can serve the purpose for circumcision, for hypospadias, for hemorrhoids. So why do you need to go to the Alcox canal?
basic the idea to give block at the level of Alcock canal is this. This inferior rectal nerve, it leaves pudendal canal at around 3 centimeters from posterior. Okay, it does not traverse at the level where you give your block. At the transperineal level, it is already moved to
Correct.
the. um,
So
So
the
this is
point
the idea.
is, because when we are using the anterior approach, we very well know that we are not blocking the main trunk of the inferior rectal nerve. It's just the ramifications of the inferior rectal nerve towards the sphincter we are trying to block through the neurovascular plane.
So it becomes similar to ischiorectal fossa block.
See, it is
It is
anyway,
similar
if
to
you go by Dr. Hetal would vouch, we had discussed this around, I think 2014-15. And that time, I think Dr. Hetal has videos we were doing on a basis of just a click. And it was a histiorectal, basically it's a histioanal fossa block. Even when you are trying to deposit between superficial transverse peroneal and deep transverse peroneal, it's a histiorectal fossa block, which has been termed in the
no,
literature.
no. Actually, this nerve is just medial to the artery. Most of the time, it is medial to the artery. So by giving only 5 to 7 ml of the local anesthetic, you will be able to block two branches, perennial branch as well as dorsal nerve of penis. While when you give this block at the level of either Alcock canal or at the level of ischial spine, you will be blocking all three nerves, including
So I
inferior
beg
rectal
to
nerve.
differ with you. I beg to differ with you. when you are blocking using the anterior approach, you are blocking the terminal ramifications. You are not blocking the proximal is like.
Yeah,
Otherwise, why is this block? Why is
it's
this
more
block
like a field
effective for
block rather
hemorrhoid
than a,
surgery?
yeah, it is more like a
You
field block.
yourself said anterior approach as described by Dr. Teresa Paris and Rafael Blanco is effective for hemorrhoidectomy. In order for a block to be effective for hemorrhoidectomy, it has to block the inferior rectal nerve. If you yourself say that anterior approach doesn't block, then why is it effective? I have been using this block. Currently, our thesis is going on in GA patients for hemorrhoidectomy, no block versus block, and that to anterior approach. And the analgesia is 24 hours. The pack tolerance is immense. Every surgeon would like to place the pack, anal pack, for next 12 to 16 hours. So I beg to differ. If it's not blocking inferior, the terminal branches of the inferior rectal nerve, then why is it effective?
Uh, Have you seen prospect guideline? According to prospect guideline, infiltration doesn't work.
We are
They
not
do not support.
infiltrating.
They do not
See,
support infiltration.
we are not infiltrating. Please try to get it very clear under ultrasound guidance. I'll show my videos. We are depositing the drug as shown by Teresa Pare in the plane either between superficial and deep or in the substance of deep transverse peroneal.
Yeah.
Sangamitra, can you allow me to share my screen?
Yes, sir, you can share, sir, please.
Thank you very much. Is my screen visible?
Yeah.
So what we are, see, anal canal is somewhere here. Our probe is here. I'll show you the. So we are not blocking the main trunk of the inferior rectal nerve. We are blocking the terminal ramifications. That is why it is effective. So the same has been, this is a screenshot from Dr. Tarkavi. He has made a beautiful video on YouTube. You must watch through it. See, this is the anococcygeal ligament. This is how it is coming. In the next screenshot, he very clearly shows the muscles and the ligaments at the proximal point. And this is from essential anatomy. This is superficial transverse peroneal. This is deep transverse peroneal. So our probe is somewhere here. You are trying to align according to it. I keep it this way. So I get a definite click. And this is how the terminal branches are traveling. This is the proximal. This is the terminal ramifications. What I mean is the terminal divisions. So once we place the drug in this place, these nerves are likely to be blocked. So this is the position. This is how we do it. 1 second. Now I'll play my video. So in this plane between the anal verge and the ischial tuberosity, if you deposit, so it is inferior to the superficial transverse peroneal, but somewhere close to the substance of deep transverse peroneal. So you have to infiltrate. I generally use 10 mLs of 0.3% ropivacaine with 4 milligrams of Dexona on each side. And obviously kids, we use 0.2 to 0.4 ml per kg. So outer plane becomes a little easier and we get a visible click as we
Definitely,
traverse them.
definitely, you get a definitely click is there, but I think when you can block main branch, why to block terminal branches?
That is personal choice to choice, but I think we are getting good results. So that means we are blocking. Others are there, Dr. Ankit or Dr. Hetal. Any other comments on this?
I usually prefer to give block at the level of Halcock canal,
But you
Even
showed that paper in which it is
50%.
50% chances they are still proximal. But
Yeah.
in the anterior approach, whether the nerve has diverged away at the level of spine or in the Ilcox canal, the terminal branches would definitely be traveling through that fossa.
Basically,
So we are likely to catch that.
your block is equivalent to ischiorectal fossa block. Infiltration
You may
basically
call that.
equivalent to it is
See, I will
basically
not call it infiltration. Under ultrasound, it's very precise. You are locating the neurovascular plane. It is not infiltration. Infiltration means all along the anal canal. That's what my understanding is what they mean by infiltration. I may be wrong on that.
Will it cover posterior part as well? I really doubt about
Posterior
this.
part of what?
Anal verge.
See the हमारा idea क्या है hemorrhoid में? It's the internal portion which is supplied by the inferior rectal nerve. So
Sometimes,
terminal ramifications are ऐसे आ रहे हैं. I may be wrong, I don't know, but I am getting very good results with this.
actually, we can compare. That will be a better idea rather. Uh,
Obviously, the
as
next thesis we can give is anterior approach
Alcock
versus
canal.
the Alcock's canal approach. We can do that.
Even this
I mean,
giving Alcock canal block it is not very difficult. It is not very
see,
difficult. Even with the penis, it's simple, not very difficult.
the point is you have to keep a good size wedged so that the pelvis
Yeah,
is rotated
yeah,
like this. That
definitely,
is the
definitely,
key.
definitely, definitely.
And our surgeons are very fond of that position because I asked my surgeons to give it because they themselves operate in that position for him, right? So it is not at all difficult. Whether you wish to do this approach or move little posteriorly, both ways you can visualize. It is not at all difficult. Any comments
Sometimes,
from bolo bolo Shishir, आप बोलो.
sometimes even if I am not available, my surgeon used to give block blindly. This at the level of Alcock canal. He usually hit this still tuberosity, and after withdrawing, he deposit around 10 ml of the local anesthetic, both sides.
But ischial tuberosity is this big. Once we talk of ischial tuberosity, it has to be the
It is big.
lowermost point.
Yeah,
Big.
distal, proximal most. Yeah.
Yes. Towards the posterior aspect, if you
Towards
go,
the
that is
posterior.
the
Yes,
yeah.
yes, definitely, definitely. As posterior as you can go.
Ankit, you were saying something.
Yeah, so I prefer to give mainly my experiences with hypospadia surgery. So we prefer to give close to the Alcock's canal, but even if we give close to the Alcock's canal, whenever we are doing a pinoscrotal hypospadias, especially when they are operating near the scrotum, there is always some amount of response at that level. So at that level, somehow we miss some of the nerves. So basically, we always prefer to still give caudal over these blocks because caudal will give complete analgesia, whereas if you give this bilateral pudendal nerve block, it still doesn't give your complete analgesia. So we basically look for complete anesthesia. The only advantage of these blocks is longer analgesia. So that we can easily cover by adding some additives like clonidine to our caudal block. So our practice is to mainly use caudal analgesia. Very rare cases we use bilateral pudendal nerve blocks. In those blocks, my technique is we give at the level of the Alcock's canal. And as you said, we prefer to go out of plane because most of the times there is no space to give go in plane in very small children. And somehow the difficulty that we face is holding the probe. So for holding the probe, I think Shishir had shown that in one of the slides. So we try to hold the probe by resting our arm against the table. So that is what we prefer. If we do that, then otherwise it becomes very difficult to give the block practically. So we try to give a position, a frog-like position, and try to hold the probe in a way that the arm is resting against the table. So that is our technique. But even so, still we find that in very severe pinoscratal hypospadias, the analgesia is not complete.
Actually, the region behind the actually scrotum has a huge nerve supply. Anterior part is supplied by the genital branch of the genital femoral, ilioinguinal, and posterior most part is supplied by the posterior cutaneous nerve of the thigh. This may be a region of failure of this block.
Yes.
Yeah, yeah.
So initially, Shishir's one of your diagrams depicted very well that there's a huge chunk which is covered on this side when you look at the scrotum from the lithotomy position by the posterior cutaneous nerve of the thigh. So that explains very well what Ankit is pointing out, that not all hypospadias would be covered by this. So any infiltration if tried on that area, Ankit, can be helpful in addition to pudendal.
Yeah, it would be helpful, but surgeons don't like to infiltrate in hypospadia
Okay.
surgeries. They are not very fond of infiltration. Sir.
And addition of clonidine in caudal, how much long does it prolong? Like caudal roughly lasts 6-8 hours. With clonidine, how much long will it
So generally we
last in
use
your
1
experience?
microgram per kg. With 1 microgram per kg, usually the analgesia lasts for around, I think, 12 to 14 hours. But usually we start diclofenac and paracetamol immediately. So the analgesia is always there for the first 24 hours with multimodal analgesia. And regarding that controversy, which I think Shishir has mentioned, we work
Retrocutaneous
with
fistula.
yeah. So it is, I think, a bit it is not a proven thing. Uh, like a lot of people previously, like when the initial study, I think, was from one of our institutes. I think it was from JIPMER. I think Dr. Pankaj Kundra was one of the part of the study. It was a retrospective study where they found that there was some the incidence of urethrocuteneous fistula was a bit high in cases where caudal was given. So a lot of studies came up where people started blaming caudal for this urethrocuteneous fistula. Whereas if you see hypospadia surgery is a very complex surgery. There are a lot of, anyways, the results are very guarded. It is not 100%. And a number of factors are there. Like the same hypospadia surgery, different surgeons would do different surgeries even for the same hypospadias. So surgical factors are responsible for a number of like urethrocuteneous fistulas. So caudal as a causal factor for urethrocuteneous fistula is not proven, and you can give caudal for hypospadia surgeries. But as Shishir rightly said, the advantage of not giving caudal and using dorsal penile or your these pudendal nerve blocks is less urinary retention and probably longer analgesia. So that you have to like balance the risk benefit ratios and accordingly select your techniques. But caudal is not contraindicated. That is something that you have to remember.
Definitely, Ankit. We are using caudal block as well for the hypospadias surgery. Actually, most of my colleagues are using caudal block, but only in few patients we are using pudendal block. Actually, in very small kids, it is sometimes very difficult to identify, to hold this probe and to give this block because positioning is difficult, needle probe handling is difficult, needle manipulation is difficult. So in very small kid, caudal block is good, but in relatively bigger child, we can give this hypospadias, this pudendal block.
Yeah, absolutely.
Shishir sir, there's a message from Neeta ma'am. She's asking a question. Is there any experience of methylene blue as
No,
adjuvant?
no, never, never used this.
Okay, sir.
Any questions from fellows? Anyone wants to comment or any questions?
Any difficulty in any techniques, you can ask me.
Sir, I have one question.
Yes, please.
Sir, any comment on comparison between a sacral multifidus plain block and a pudendal block?
Mm, No idea.
Uh,
I have no idea.
okay, so because I was actually planning to take this as a project, so I was not very sure of it. So I just thought I'll ask the
So
comparison.
you can compare with the still spine approach because in both the way you need a prone position for both the blocks, multifidus plain block and for the still spine approach. You can do this
Okay,
as well.
okay, thank you.
Thank you, Dr. Hital and rest of the fellows, Dr. Devesh, Dr. Ankit. Thank you, Vedal, all of you. I think my talk was clear and I was able to show you all the technique properly.
It was very crystal clear, Shishir, from A to Z, right from the PNS till all three approaches, very well presented. Very beautifully you explained.